My topic for today's discussion is congenital cyanotic and acyanotic heart diseases in children. Okay, this is the outline of my talk. We will talk about the prevalence of congenital heart diseases and then the evaluation of an infant or a child with suspected congenital heart disease. This will be followed by classification of CHDs, and then we will talk about the common acyanotic and acyanotic congenital heart lesions, their clinical features, how do we diagnose these problems, and their management and prognosis. And in the end, I will take your answer your questions. Okay. As far as the prevalence is concerned, congenital heart disease occurs in approximately 0.8% of the live births, and the incidence is much higher in stillborn infants and in spontaneous abortions, and also in premature infants, about 2%, excluding patent ductus arteriosus. Okay, so the overall incidence does not include mitral valve prolapse, PVA of preterm infants, and bicuspid aortic valve. And in cases of congenital heart diseases, especially the cyanotic heart disease, the diagnosis is established by 1 week of age in 40 to 50% of the cases, while diagnosis is made by around 1 month of life in 50 to 60% of the patients. Okay. Now, let's talk about the evaluation of these children in whom we suspect congenital heart disease. We can broadly divide congenital heart diseases into two major groups based on the presence or absence of cyanosis, which can be observed clinically, and it can also be observed with the help of a pulse oximeter. Secondly, these two groups can be further subdivided according to whether the chest radiograph shows evidence of increased, normal, or decreased pulmonary vascular markings. Okay, then ECG help us to determine whether there is right, left, or biventricular hypertrophy. The character of the heart sounds, that is the presence of murmur, also narrows down the differential diagnosis. But here, a very important point is that absence of murmur does not rule out congenital heart disease. Okay, so whenever there is no murmur and the child presents with central cyanosis, we have to consider congenital cyanotic heart diseases. Okay, the final diagnosis is confirmed with the help of an echocardiography, and CT and MRI and cardiac catheterizations. These modalities are not required in every case. Usually we need an X-ray, an ECG, and echocardiography to make the final diagnosis. Okay, this slide shows relative frequency of major congenital heart diseases. Here we can see that ventricular septal defect, that is VSD, is the most common of all the lesions, and it accounts for around 30 to 35% of all the congenital heart lesions. This is followed by atrial septal defect, which accounts for about 6 to 8%, patent ductus arteriosus, coarctation of aorta, then the cyanotic heart diseases like tetralogy of FALLOT, transposition of great vessels. These are less common as compared to acyanotic congenital heart diseases. Okay, now we will talk about classification of acyanotic congenital heart diseases. We can classify acyanotic congenital heart lesions in the lesions which result in increased volume overload. That is, there is shunting of blood, mostly from left to right side of the heart, and these defects include ventricular septal defect or VSD, atrial septal defect or ASD, or PDA, that is patent ductus arteriosus. Now, there are also lesions, acyanotic heart lesions, which result in increased pressure overload. These include pulmonary stenosis, aortic stenosis, and coarctation of aorta. Okay. Similarly, we can also classify cyanotic congenital heart diseases on the basis of decreased pulmonary blood flow or increased pulmonary blood flow, which can be seen in X-ray chest. So cyanotic lesion with decreased pulmonary blood flow include tetralogy of FALLOT, tricuspid atresia, and various forms of single ventricle with pulmonary stenosis. So if obstruction is severe, pulmonary blood flow may be totally dependent on PDA, and these children, these babies even can present in the newborn period if there is severe obstruction. As soon as the PDA will close, they will present with cyanosis and respiratory distress. The second category of cyanotic congenital heart lesions are those in which there is increased pulmonary blood flow. So these children present not only with cyanosis but also with signs of congestive cardiac failure. The defects include transposition of great vessels, total anomalous pulmonary venous return, truncus arteriosus. These are also duct-dependent lesions. Okay, now having overview of congenital cyanotic and acyanotic heart diseases, we will talk about ventricular septal defect a little bit in detail. VSD or ventricular septal defect, as we have seen in the previous slide, that this is the most common of the congenital heart lesions, and it accounts for around 25 to 30% of all the congenital heart diseases. We can further divide the types of VSD based on their anatomical location and based on the size of the defect. Okay, VSD is called membranous VSD if it is located in the membranous part of the ventricular septum. It is called muscular VSD if it is located in the muscular part of the ventricular septum. And VSD is called supracrystal VSD when it is present just above the cusp of aortic valve. Okay, VSD is called a smaller pressure restrictive VSD when the size of the defect is less than 5 millimeters, and it is called large or restrictive VSD when the size is more than 10 millimeters, or I can say it when the size is more than 1 centimeter. So this is how we classify different types of VSD based on their anatomical location and based on their size. Okay, in a small VSD, the right ventricular pressure is normal. The higher pressure in the left ventricle drives a shunt from left to right, and the size of the defect limits the magnitude of the shunt. It's mean in a small VSD, there is a small amount of shunting of blood from left to right because of the size of the defect. On the other hand, in large VSDs, right and left ventricular pressure are equalized, and the direction and magnitude of shunt are determined by the pulmonary to systemic vascular resistance. So how these children present to us in OPDs and in the emergency department. The clinical features of patients with VSD vary according to the size of the defect. As we have seen that the smaller VSDs, they produce mild symptoms. On the other hand, large VSDs, they can present with signs of cardiac failure and also with signs of pulmonary hypertension. Like these babies can present with dyspnea, feeding difficulties. Because of the underlying cardiac failure, these babies have difficulty during feeding. As a result of poor feeding, their growth is affected. When they are in cardiac failure, they perspire profusely, and sometimes they are being treated as having recurrent pulmonary infections. Actually, they are having signs of cardiac failure, and they develop cardiac failure early in infancy. So on examination of patient with a large VSD, because we may get cardiomegaly, prominence of the left precordium, and left palpable parasternal lift. Apex bead may be displaced, an apical thrust may be palpable, and a systolic thrill can be palpable. Systolic thrill or thrill is basically a palpable murmur. A hollow systolic or a pan-systolic murmur of a large VSD is best audible over the left lower sternal border, and it is blowing in nature. And when the patient develops pulmonary hypertension, the second component, the second heart sound may be loud enough. Okay. On the other hand, smaller VSDs with trivial amount of left to right shunt and normal pulmonary arterial pressure, they are sometimes asymptomatic, and the cardiac lesions are usually found on routine physical examination. Okay, so they are not that dangerous as compared to large VSDs. Characteristically, a loud and harsh murmur is audible at a similar location, that is left lower sternal border. The smaller the murmur, the louder and harsh will be the smaller the size of the defect, the louder and harsh will be the murmur. This is the X-ray of a child with ventricular septal defect. Here you can appreciate there is massive cardiomegaly. In fact, there is biventricular hypertrophy. Okay? Biventricular hypertrophy, and there is increased pulmonary markings. Okay. Now, what the ECG of a child having VSD shows? The ECG shows biventricular hypertrophy. P wave may be notched or peak due to the enlargement of the atria. And then, as I have said, that echocardiography is basically required in order to make the diagnosis, in order to locate the position and size of a ventricular septal defect. Pulsed Doppler examination shows whether the VSD is pressure restrictive by calculating the pressure gradient across the defect. Okay, now let's talk about the treatment aspects of a ventricular septal defect. A significant number, that is 30 to 50% of small defects, they have potential to close spontaneously, and most of the defects are closed during the first 2 years of life. And among the different types of VSDs, small muscular VSDs are more likely to close spontaneously. That is, up to 80% of the small muscular VSDs, they have potential to close spontaneously, while membranous VSDs, they can, up to 35% of the membranous VSD, they can also close spontaneously. Okay, so we can wait for the closure of the defects after the before the 4 years. Yeah, but if the patient is symptomatic, we have to go for medical and surgical interventions. Okay, so what should be the target of management of these patients? So management basically has two aims: to get the symptoms of heart failure under control and to prevent the development of pulmonary vascular disease. Okay, now what are the indications for surgical closure of a ventricular septal defect? These include, number one, patients at any age with large defect in whom clinical symptoms and cardiac failure to thrive cannot be controlled medically. So this defect is large, and as a result of this large defect, there is huge amount of shunting of blood from left to right, and the patient remains in cardiac failure. As a result, the growth is affected. So we have, and the symptoms are not controlled medically, so we have to go for surgical closure, VSD. Number two indication is infants between 6 and 12 months of age with large defects associated with pulmonary hypertension, even if the symptoms are controlled by medication. Third indication for surgical closure of a VSD is patients older than 24 months of age with QP-QS ratio, that is pulmonary to systemic ratio, circulatory ratio is greater than 2:1. Then if a patient has a supracrystal VSD, it is a straight away indication for surgical closure of the defect, because if we delay surgery in case of a supracrystal VSD, it will lead to aortic valve regurgitation. So at any age, if the echocardiography shows that the child is having a supracrystal VSD, that is the VSD located just above the cusp of the aortic valve, then we have to go for surgical closure of the VSD in order to prevent aortic valve regurgitation. Okay, now the guidelines of American Heart Association regarding protection against infective endocarditis. So the AHA guideline says that antibiotic prophylaxis is no longer recommended for dental visits or surgical procedures in case of a VSD. And long-term prognosis for children with VSD after successful surgery is excellent. Surgical risks are somewhat higher for defects in muscular septum. And as far as the recent advances is concerned, so cardiac catheter occlusion devices are in clinical trials as a mean of closing apical muscular VSD, and the other devices are being tested for closing the more common perimembranous defects. So this was an overview of ventricular septal defect. Now we will talk about the second most commonest of the acyanotic congenital heart disease, that is patent ductus arteriosus. Okay, little bit about its normal physiology. During fetal life, what happens? PDA, what is the function of PDA? Most of the pulmonary arterial blood is shunted from right to left through the ductus arteriosus into the aorta, and functional closure of the ductus normally occurs soon afterward. But if the ductus remains patent, when the pulmonary resistance falls, aortic blood then is shunted from left to right into the pulmonary artery, and this creates problem. Okay. Okay. So we know that among the TORCH infections, PDA is associated with maternal rubella infections. It is also more common in premature infants and also in female patients, where the ratio, female to male ratio is 2:1. Now, what are the clinical manifestations of patent ductus arteriosus? A small PDA is usually asymptomatic. On the other hand, a large PDA always results in cardiac failure. Large PDA results in bounding peripheral pulses. So this is something in examination one has to pick. If there are bounding pulses along with other signs, like on examination, if there is on auscultation, there is continuous murmur on or machinery murmur, which is localized at the second left intercostal space or radiate down to the left sternal border. This is very classical of patent ductus arteriosus along with bounding pulses. Same modalities are required in order to make the diagnosis of PDA as we used in VST. Okay, now as far as the treatment of patent ductus arteriosus is concerned, irrespective of the age, patients with PDA require surgical or catheter closure. Especially if the PDA is symptomatic, we cannot linger on. We cannot just treat patients on medical basis. We have to go for surgical closure or catheter closure of a PDA. Transcatheter PDA closure is routinely performed in the cardiac catheterization laboratory. And what about the prognosis and complications of PDA? Spontaneous closure of the ductus after infancy is extremely rare. That's why we have to go for the catheter surgical or device closure. In patients with large PDA, cardiac failure most often occurs in early infancy. And patients, when they are in cardiac failure, their growth is affected and they are failure to thrive. Pulmonary or systemic emboli may be a complication of PDA. Pulmonary hypertension usually develops in patients with large PDA. Okay, so this was the overview about the two common acyanotic congenital heart diseases, namely ventricular septal defect and patent ductus arteriosus. Now we will talk about cyanotic congenital heart lesions, and among the cyanotic heart lesions, the very important is tetralogy of FALLOT. Now, what are the components of tetralogy of FALLOT? It has four components. Number one, obstruction to right ventricular outflow, that is pulmonary stenosis. The second component is a malalignment type of VSD. The third component is overriding of aorta. And the fourth component is right ventricular hypertrophy. This is the diagrammatic representation of tetralogy of FALLOT versus a normal heart. Here we can see there is overriding of aorta, pulmonary stenosis, ventricular septal defect, and right ventricular hypertrophy. Now, what are the clinical manifestations of tetralogy of FALLOT? Often, cyanosis is not present at birth, but with increasing hypertrophy of the right ventricular infundibulum, as the patient grows, cyanosis occurs later in the first year of life. Here, one thing is very important to understand, that presence of cyanosis or occurrence of cyanosis will depend on the severity of infundibular or pulmonary stenosis. So if the infant have severe degree of right ventricular outflow tract obstruction, that is severe degree of infundibular or pulmonary stenosis, they can present in the neonatal period. Okay, so so it all depends on the severity of right ventricular outflow tract obstruction. Okay, so older children, the clinical presentations in older children with long-standing cyanosis, who have not undergone surgery, it includes they may have a dusky blue skin, they may have gray sclera with engorged blood vessels, and marked clubbing of fingers and toes because of chronic hypoxia. Now, what are TET spells or paroxysmal hypercyanotic spells or hypoxic spells? Okay, these are basically problem in children after the first year of life, mainly in second year of life. What happens when the infant suddenly becomes hyperrhythmic and restless with increased cyanosis, gasping respiration, and sometimes they develop also fits or syncope may follow this episode of hyperrhythmic spells. Okay, this is the X-ray of a child with tetralogy of FALLOT. Here we can see that oligemic lung fields, that is decreased pulmonary blood flow, and the very classical boot-shaped heart, that is because of the hypertrophy of the right ventricle. So in this X-ray, you can easily identify that this is an X-ray of a child with tetralogy because of the presence of boot-shaped heart on secondary to right ventricular hypertrophy and oligemic lung fields. Again, echo is required in order to find out all the components associated with tetralogy of FALLOT, which we have just discussed. Okay, there are certain syndromes in which the tetralogy is common. For example, Down syndrome is associated with atrioventricular septal defect as well as tetralogy of Fallot. Similarly, TOF can also be associated with Digeorge syndrome, which is also remembered by the acronym CATCH 22, that is cardiac defects, abnormal facies, thymic hypoplasia, cleft palate, and hypocalcemia. So these are the two common syndromes which are associated with tetralogy of Fallot. Or we can say that these syndromes can have tetralogy. Okay, as we have just discussed the TET spell, we should know how to manage this TET spell. Okay, that is basically what happens on a child having tetralogy. If he or she presents in the emergency department with increased degree of cyanosis, gasping respiration, or having seizures, we just have to do few things in order to manage this child. We have to calm the baby and hold the child in knee chest position. This simply may abort the progression of an early spell. We have to administer oxygen, although in cases of cyanotic congenital heart lesion, when there is mixing of deoxygenated blood, oxygen is not that helpful, but we have to give it. Injection morphine is used subcutaneously in order to calm down or sedate the child, because irritability and restlessness further exaggerate the severity of the. For correction of metabolic acidosis, we can use a small bolus of normal saline from 5 to 10 ml per kg. We can also use soda bicarbonate in order to correct metabolic acidosis. Similarly, prevention of hypoglycemia and hypothermia is very, very important, because both these can cause exaggeration of a TET spell. For spells that are resistant to this therapy, intubation and sedation are often sufficiently required to break the spell. Okay, during that increased systemic vascular resistance, there are certain medications which are used in order to manage this TET spell. These medications are phenylephrine, which is a vasopressor drug, and it basically improves right ventricular outflow. It increases systemic vascular resistance, and it decreases right to left shunting of blood, and this is how it improves symptoms. We can also use beta-adrenergic blocker drugs, for example, propranolol, which decreases the spasm or infundibular stenosis, severity of infundibular stenosis, and helps in reverting the TET spell. Okay, the definitive treatment is obviously surgery, that is in neonates with marked right ventricular outflow tract obstruction. They may deteriorate rapidly. So ductus has, as the ductus begins to close. So first of all, what we have to do in order to buy time, we have to start intravenous administration of prostaglandin E in order to keep the ductus patent and in order to buy time for surgical procedure. Because prostaglandins can cause apnea, so individuals skilled in neonatal intubation should be readily available. If we are going to start prostaglandin, one has to have ventilatory support, because as a complication they can cause apnea. Okay, corrective surgery for tetralogy of Fallot consists of relief of right ventricular outflow tract obstruction and patch closure of the VSD, and also for stenotic pulmonary valve, we can go for valvotomy. Okay, so what are the complications these children with tetralogy of Fallot can have? We know that polycythemia occurs whenever there is chronic hypoxia, and in children with tetralogy of Fallot, because of the mixing of the oxygenated blood with oxygenated blood, they always have hypoxemia. This hypoxemia results in polycythemia. Polycythemia leads to hyperviscosity, and this hyperviscosity can cause cerebrovenous thrombosis, especially in cases of dehydration. For example, if a child who has tetralogy develops diarrhea, so he already has polycythemia and now he has become dehydrated, this will exaggerate this polycythemia and hematocrit level, and this can lead to cerebral thrombosis. Brain abscess is less common than cerebral vascular events in these children, but these children can also develop brain abscess because of the thromboembolic complication. Bacterial endocarditis is a life-threatening complication which these children can develop. Heart failure is not a usual feature in patients with tetralogy of FALLOT. Why? Because of the infundibular stenosis, there is less amount of blood which is going towards the lungs, and when less amount of blood goes towards the lung, there will be less chance of development of pulmonary edema and cardiac failure. But in cases where the spondylolar stenosis is mild, for example, in patients with acyanotic TOF or pink TOF, where the infundibular stenosis is mild, they can develop heart failure. Right bundle branch block is quite a common complication after surgery or your corrective surgery of tetralogy of patients. So this is, we can say, a post-op complication of tetralogy. Okay. After discussing the tetralogy, now we will talk about another very important cyanotic congenital heart defect, and this includes transposition of great arteries. Okay. So what do we understand by transposition of great arteries? We know that what happens that in transposition of great arteries, the aorta arises from right ventricle and the pulmonary artery arises from the left ventricle. And opposite is true normally. We know that aorta arises from left ventricle and pulmonary artery arises from the right. But here, the arteries are basically transposed. So desaturated blood returning from the body to the right side of the heart goes in appropriately out of the aorta and back into the body. Similarly, oxygenated pulmonary blood returning to the left side of the heart is returned back to the lungs. So this is a sort of parallel circuit where oxygenated blood is going back to the lungs and deoxygenated blood is going back to the body. So patient presents with cyanosis. And 50% of the cases of TGA, they also have a ventricular septal defect. So this is an associated finding. Isolated TGAs are basically not compatible with life. TGA is more common in infants of diabetic mothers and in males with female male to female ratio of 3:1. Now, what are the clinical manifestations of transposition of great arteries? Cyanosis and tachypnea are most often recognized within the first hours or days of life. We know that this is a duct-dependent lesion. So when the ductus will close, the patient presents with cyanosis and respiratory distress. This condition is a medical emergency, and only early diagnosis and appropriate intervention can avert the development of prolonged severe hypoxemia and acidosis, which can lead to death. So again, a duct-dependent lesion where we have to start prostaglandin infusion as early as possible. The second heart sound is usually loud and single, and it may be split. Murmur may be absent. And in the beginning of my lecture, I told you that absence of murmur does not rule out cyanotic heart disease or congenital heart disease when the patient presents with severe cyanosis. But we do get an ejection systolic murmur at the mid-left sternal border in cases or few cases of transposition of great arteries. ECG of a patient with transposition of great arteries shows expected neonatal right-sided dominant pattern. X-ray is very, very classical. This is very important for you to understand what are the X-ray findings of a patient with transposition of great arteries. Along with mild cardiomegaly, there is narrow mediastinum, and this gives a classic egg-shaped heart, that is egg on a string appearance and with normal to increased pulmonary blood flow. Here you can see the narrow mediastinum, okay, and mild cardiomegaly, and shape of the heart is just like an egg. So egg, we say egg on a string appearance with narrow mediastinum. And here we can see pulmonary edema or increased pulmonary markings. Okay? So these patients can have signs of cardiac failure because of this pulmonary edema. Now, what is the management of transposition of great arteries? As I have said, that these patients present very early, just after a few hours of birth, especially if the TGA is isolated. So then we have to keep the ductus patent, and for that purpose, we have to start an infusion of prostaglandin E as early as possible, because we have to prevent closure of the ductus, and we have to improve oxygenation via ductus arteriosus. Again, we have to avoid hypothermia, hypoglycemia, and metabolic acidosis, because these all, they can make the condition worse. And obviously this will be followed by surgical closure of the defect. Okay, if you have